Hello, welcome to this lecture on the surgical management of optic pathway hypothalamic low-grade gliomas. My name is John Gooden, I'm consultant neurosurgeon in Leeds, and I've written this chapter jointly with Professor Conor Malucci from Alder Hey Children's Hospital in Liverpool. Through this lecture, we're aiming to give you an initial overview of the therapeutic aims of treatment and of surgery, and then look at the role of surgery for optic pathway hypothalamic glioma, and then cover some of the principles of surgery and the operative anatomy, particularly with regard to a midline transcallosal approach. We then move into a section where we look at an overview of the outcomes and some case examples, and some specific focus on radiology and radiomics before entering the conclusions. So when we're talking about surgery for OPHD tumours, we've got to bear in mind that these are children and adolescents that are going to be with us for a long time, and we're trying to gain time by controlling their tumour progression, preserving their function for as long as possible. It's really important that this surgery is done and that all treatment is done, in fact, as a multidisciplinary treatment, that we've got careful decision making with committed neurosurgeons, committed neuro-oncologists working together for the benefit of the patients. And this was summarized very nicely by this diagram from the Necker team in Paris. The need for an enthusiastic neurosurgeon working with an enthusiastic oncologist working together to get the best outcome for their patients. When we're looking at optic pathway tumours, we're looking at a long-term disease. If you look at the blue line on this graph, we've got vision here, which starts off good and typically declines over the course of treatment. And if we look at the tumour, of course, the tumour is growing, and that may go through a period of stability and then carry on growing again. Our normal perspective, certainly as surgeons, is to look at a fairly narrow window of a fairly focused time of treatment. But in fact, if we're looking at this, particularly with optic pathway tumours, we're talking about a long disease process, and vision can deteriorate over that period. The tumour can grow over that period, and we need to think of the role of surgery within this whole curve as to whether we need surgery up front or later on, and when is the right time to think about that. So with this, we're trying to think about, right, when and if to offer a biopsy prior to non-surgical treatment. Is that the only time, or do we need to do it at some other time during the treatment? If we're thinking about starting a non-surgical treatment due to a threat to vision, then doing a biopsy is often a very important thing, especially now that we're getting an improved molecular understanding of tumours, of the biology, when we're trying to target our treatments. And for example, with the newer BRAF inhibitors, we need some molecular data to know whether we've got a BRAF fusion or whether a MEK inhibitor will be the right treatment to offer for this particular patient. And then what about the role of surgical primary tumor debulking? Well, this isn't absolute standard of care, of course, but it does have a role, though. And it may have a role, particularly if MDT discussion identifies patients where there's characteristics that early surgical debulking would be helpful. For example, cystic tumours. If there's a tumour cyst compressing the optic pathway, that could well be a suitable target for surgery. But that would be for a focused operation to debulk the cyst. Or large tumours with raised intracranial pressure, or exophytic tumours as well. So here are some examples of what could be considered to be typically non-surgical tumours. A tumour, for example, within the optic nerve. Now, of course, if it's purely the optic nerve and not involving the chiasm, then there may be a role for surgery, but we're not going to get into that area of discussion today. In general, a lot of the optic nerve tumours have already got chiasmatic involvement. A tumour that's purely restricted to the chiasm would not be a suitable target for surgery, because by doing any form of surgical debulking of this tumour, we will cause damage to the visual pathways. Similarly, a tumour affecting the optic tracts, such as in this lower set of MRI scans, again, a debulking of that tumour will lead to a loss of visual field. So these are tumours that would not be typically suitable for a surgical debulking. However, these are 3 examples of tumours that would be potentially suitable for surgery. And you may recognise these scans from our book chapter. So the first 2, the cases 1 and 2, these are tumours with a large tumour bulk. And so as a result of these, we've got raised intracranial pressure. And in this case, we've also got some hydrocephalus. We've also got a cystic portion of the tumour. So debulking the tumour to relieve raised intracranial pressure is a potential role for surgery for these 2 patients. This bottom patient here, we'll talk about later on in this lecture, but he's presented with hydrocephalus, and the role of surgery initially was to obtain tissue, a biopsy, so that chemotherapy could be started, and also to perform a septum pellucidotomy to allow a single-sided shunt to drain both lateral ventricles, because both foramina of Monro were obstructed by the tumour. When we're thinking about surgery itself, we also want to think about what tools we've got available. Navigation, optical or electromagnetic, use of ultrasound during surgery to help guide us with our extent of resection, use of endoscopy to help look round the corner, or to do a biopsy, as with that last case I was just talking about. But of course, if you are planning an endoscopic biopsy, make sure you've got a working channel that will actually take your biopsy forceps. With some of the smaller newer endoscopes, a number of the biopsy channels, a number of the working channels won't necessarily be big enough for a biopsy. And then we've got, of course, intraoperative MRI scan. On the picture on the slide is a picture of our 3T wide-bore intraoperative MRI scanner that we've got in Leeds. And this can be a very useful tool in helping to optimize the extent of resection, balancing the extent of resection with the preservation of function. So when we're thinking about surgery, we're trying to think about what can we do safely. Total excision of tumour is generally not the goal of surgery. We're aiming to debulk an exophytic portion of tumour and preserve function, but we're not seeking to totally remove the tumour, because of course this tumour is arising from the optic pathways. So as we get down through, for example, a tumour that's exophytic into the third ventricle, as we debulk through that down to the base of the tumour, we are then starting to reach hypothalamic tissue and the optic pathways. And so if we go into these, we will cause a deficit. So we're trying to optimize the extent of resection whilst preserving the surrounding tissue. And if we go back to that example of an exophytic tumour within the third ventricle, what we're typically trying to do is remove the central portion of tumour and leave tumour around the lateral margins, around the base as well. And that way we can preserve the optic pathways and the hypothalamus. And you'll see this illustrated in a minute on subsequent slides. The surgical anatomy of the third ventricle and the surrounding structures is really key. And so if you are in that position where you're thinking about surgery for a third ventricular tumour, you need to know the anatomy. You need to be familiar with the location of the tumour in relation to the fornices, the hypothalamus, the optic pathways. Where's the infundibular recess? Where's the pituitary? Where's the chorioplexus? Where are the important deep cerebral veins? We need to know where these things are so that we can preserve them. When we're thinking about the approach for surgery from midline into hemispheric approach, we've also got to think about the arterial anatomy as we're coming in. So as you can see highlighted on this slide, you've got the pericallosal arteries, but you've also got the callosal marginal artery running around the cingulate gyrus. And it's very easy as you go in doing the interhemispheric approach to mistake the callosal marginal artery for the pericallosal and start actually cutting through the cingulate gyrus instead of the corpus callosum. So it's very important to be careful about the anatomy. Similarly, the deep venous anatomy is very, very important as well. You can see here on this slide that we've got the fornix, and as it goes around the foramen of Monroe, we've got the thalamus striate vein here, and being aware of the relationship between the fornix, the septal vein, the thalamus striate vein, the choroplexus is all a very key part for this midline interhemispheric approach. So here's an example of a 9-year-old who presented with visual deterioration. Now, if you go online to our chapter, there's a video of the midline interhemispheric approach in detail, and also of the debulking surgery for this girl for her tumour. I've used a few screenshots from that operative video as part of this lecture, and you'll see that on the subsequent slides. Firstly, when making the craniotomy, it's typically described as being between 4 and 6 centimetres, centred 2/3 in front and 1/3 behind the coronal suture. And the purpose behind having a craniotomy of this sort of is to account for veins that can be draining from the brain surface into the superior sagittal sinus, and these veins may restrict our access. So if you've got a slightly longer craniotomy, that gives you the opportunity to vary your approach and vary your dural opening to make sure that you preserve those veins. You can also predict these looking at the preoperative volume T1 post-GAD scan, looking to see where the veins are on the cortex and see, right, is there going to be a difficulty in these locations? And you can see on this operative video, you can see that on this still, that I have preserved this part of the dura here on the side, and preserving that was necessary because there was a cortical vein coming in and draining into the dura, meaning I needed to move my approach posteriorly a little bit. So as we come in, you often need to put a cottonoid patty over the brain surface, and I typically put Surgicel on there as well. And Surgicel, the reason I use Surgicel is it stays as a sheet and it can be lifted off very easily at the end of surgery. But it also protects the brain surface, it can seal any minor bits of bleeding that happen, and it means that the cottonoid patties don't stick to the brain surface. So it becomes a very good, helpful protection to look after the brain underneath. Now, these pictures are taken from Fred Mayer's Atlas of Neurosurgery, and particularly, as you can see here, the green thing is a colloid cyst, but the midline approach is still the same. And you can see that with a bit of careful dissection in the middle, you can open up the interhemispheric space beside the falx and the frontal lobe and start to come down to expose the pericallosal arteries and the corpus callosum. And you can see this in these operative videos as well. The picture on the left, you can start to see the silvery falx over to the left-hand side, and my number 11 dissector and sucker just gradually breaking down the adhesions between the frontal lobe and the falx. And now with further dissection, moving into the right-hand picture, you can now see the right pericallosal artery just by the tip of my number 11 roton dissector, and then the bright white shiny corpus callosum with my sucker on it. And this is where I'm starting to expose. I've broken down a number of the adhesions here, and I'm getting ready to start my corpus callosotomy. Now, when doing the corpus callosotomy, it's very important to identify the pericallosal arteries, and you take the ipsilateral artery to the ipsilateral side. So you need to make sure that you've identified both the pericallosal arteries, so that you can take the right artery over to the right and the left artery over to the left, so that you don't cause an inadvertent stroke. Another very useful and very helpful technique is to take either a small cotton ball or take a cottonoid patty and roll it up and put it at the front and at the back of your surgical exposure. And this just helps to provide a bit of gentle retraction to hold the space open, to hold the frontal lobe away from the falx and give you a surgical corridor, meaning that you need less actual retraction from a surgical retractor blade. And so it means you can be a lot more gentle with your surgery. And you can see this in these video screenshots. So here I've actually got a 1/2x1 patty, which I have rolled. You can see its string here coming up to the surface. I've rolled that, and then I've put it in, just gently holding the frontal lobe apart, away from the falx, to give me an operative corridor. And then in the middle picture, I'm starting to perform my callosotomy, which I'm performing with bipolar forceps and suction. And then in the right-hand picture, I'm just starting to get a bit of CSF coming through in the bottom of my callosotomy as I've gone through. Now, your typical length of callosotomy, you don't want to exceed 2.5 centimeters, because that can lead to a disconnection syndrome. I typically find that 12 to 15 millimeters is enough for my third ventricular surgery. And in doing that, I also know that I've got plenty of leeway. I've got a margin that if I need a bit more, I've got a bit more available. But actually, typically I find 12 to 15 millimeters is a long enough callosotomy. If you don't need 2.5, don't make a 2.5 centimeter callosotomy. Keep it small enough to do the right job so that we can avoid these risks of things like disconnection syndrome. Now, as you come down through the corpus callosum, you then have a choice. As is shown on the left-hand side, you can choose to go into either of the lateral ventricles or midline between the two halves of the septum pellucidum, down between the two fornices, as a true interforniceal approach. This slide, taken from Operative Neurosurgery by K.M. Black, shows the choice of really 4 different operative corridors that we have. One is an interforniceal approach, coming between the two halves, the two bodies of the fornices. I actually prefer coming through into the lateral ventricle and taking either a transforaminal or combining that with a transforaminal and suprachoroidal approach. You can also make a subchoroidal approach. The reason I prefer a transventricular, transforaminal, suprachoroidal approach is it allows me to open up the foramen of Monro posteriorly, gives me a very good access to the third ventricle to debulk a third ventricular tumour. But it also avoids or reduces the risk of injury to the fornix itself. So I find that I can put a patty over the fornix and just gently, if necessary, gently rest against that with my sucker to just hold the fornix up out of the way whilst doing resection. But by opening up the foramen of Monro with either a suprachoroidal or a subchoroidal dissection. That gives a very good access to the third ventricle for third ventricular surgery. And this is demonstrated on this picture. So this is just after I've done my callosotomy. I've come into the lateral ventricle, and now I can see the tumour bulging through the foramen and Monro. And this is the MRI scan underneath. So you can see the right lateral ventricle is the base of the right lateral ventricle, the foramen and Monro, is filled with tumour, and that's what we see here. And then in the bottom, just below the tumour, we can see the choroid plexus, and we can see a slight hint of a vein. And then with a repositioning of the retractor, you can now see that vein a lot more clearly. So here is the thalamus striate vein. So we've got the tumour visible in the centre of a field of view. And this is shown in these illustrations as well. So you've got the choroid plexus and the thalamus striate vein, and then tumour just visible through the foramen and Monro. And moving on with that, I can then debulk the tumour. So start with some diathermy to the surface of the tumour, and then take biopsies. And of course, the biopsies are a really important part of this, because I need to spend time taking multiple biopsies of fresh tissue for the lab, for fresh frozen tumour research, for molecular analysis of the tumour, and for formal pathology. So a bit of time taken to make sure I've got adequate tumour samples at this point is really critical. By spending a bit of time on the initial exposure of tumour, once I've got that exposure of tumour, taking those biopsies, taking those right at the beginning when I'm not trying to worry about, am I about to biopsy, am I going to put my rongeurs up against the hypothalamus, doing it in an area where I can see is safe in the middle of the tumour. Taking those biopsies at that point, at the beginning of surgery, when I'm feeling fresh, is a very good time to do it. Then, having done that, I typically use a CUSA for tumour resection. Down this sort of length, an extra long tip is often required, and I'm typically using the most gentle settings on the CUSA for the tumour resection. And just like with any other tumour, I'm debulking the centre of the tumour and then working around towards the edge. And if there is a capsule, if there is a demarcation line between tumour and normal brain, then I can try and bring tumour into that cavity, or else I can just keep working gently towards the lateral margins, using my navigation, potentially with image injection down the microscope, like you can do with some of the more modern operating microscopes, to just judge exactly where am I in relation to hypothalamus, or for the tumour depth, am I getting close to the optic pathways, or as I go backwards, am I getting close to the brainstem? So having tracked navigation through the operating microscope plus minus image injection become important adjuncts to the surgery at this stage. And you can see on the scan here that the fornix is now just visible in the top of the picture with the tumour capsule and then still some tumour at the base. And as I've gone through the resection, I've then got the focal point of the microscope in the middle of the tumour, in the middle of my resection cavity. But then I've taken my navigation stellette and I've put it in to look at the anterior and the posterior extent of my resection cavity, and the deep and the right and the left lateral extent of resection as well, to help judge, have I got close to the edges of the tumour? Have I achieved my aim? And you see here the post-operative MRI scan, comparing with the pre-operative MRI scan at the top. And what I wanted to achieve was to have a debulking of the central aspects of the tumour, leaving a thin rim of tumour around the base and around the lateral margins of the resection cavity, and you can see that that's what I have achieved here with these pictures. And that's what we need to be aiming for when we're talking about debulking of an optic pathway tumour that's got a central exophytic portion. This is the sort of scan we're aiming for. We want to leave the hypothalamic tissue, and we want to leave the optic pathway tissue at the base. That way we can preserve function. And we've written up our series, published in Journal of Neurosurgery Pediatrics, 42 patients with a median follow-up of 77 months. And as you can see, quite a young age, but also quite a wide range of ages, with a median age of 5 years, 9 months, but the youngest patient of 1 year, 1 month, up to an oldest patient of 16 years, 8 months. As you'd probably expect, a fairly high proportion of patients with neurofibromatosis type 1, 42% of patients. So the presenting features and presenting symptoms of our patients, as you'd probably expect for an optic pathway tumour, 50% have got some degree of visual failure. Now, we've defined visual failure in our paper, but this was reduction in visual acuity, reduction in visual field, reduction in colour vision. 24% presented with symptoms due to the mass effect or hydrocephalus itself, and 26% presented with some form of disturbance of the hypothalamic pituitary axis, such as precocious puberty, precocious puberty, or dysfunction of the anterior pituitary gland. 3 patients had diencephalic syndrome. 10 of our patients had obesity with a BMI greater than STS2. So the management options. We had an initial watch and wait approach for 21 of our patients, and chemotherapy with a prior biopsy was used for 31% for 13 patients. And this was generally using vincristine and carboplatin as the European CEOP low-grade glioma 2 protocol. Second line was vinblastine, and third line Avastin and other BRAF inhibitors. Open surgery and debulking was used for 50% of our series. This was either used as the first intervention or used when we had progression after chemotherapy or radiotherapy. And radiotherapy was used as a treatment after progression and failure of other treatments, such as surgery and chemotherapy, but only sparingly, only for 5 patients. So, of our chemotherapy cohort, 5 patients had chemotherapy first line. One of these patients had it after a biopsy. Other patients were treated without a biopsy. Particularly, these were patients with neurofibromatosis. 10 patients had adjuvant chemotherapy given as a treatment after surgery. For 6 of these, this was within 3 months of surgery as a planned treatment intervention. So they presented with mass effect symptoms, they had tumour debulking, and then carried on to have planned chemotherapy as a deliberate staged process, but a little bit of recovery time. So it wasn't surgery and then 2 weeks later chemotherapy. We allowed them some recovery time first. For 4 patients, they had some further progression after surgery, and that was when we then initiated the chemotherapy. And this ranged from 4.6 months to 35.6 months, so almost 3 years after surgery. For those having surgery, we had 2 patients who just had a biopsy, and then we had 22 debulking operations on 21 patients, so 50% of our cohort. The main indication for primary surgery was for when there was a large exophytic tumour with raised intracranial pressure or hydrocephalus, and that was the case in 14 patients. We divided our patients for analysis into 3 groups. Group 1 was those who had a primary debulking surgery only. Group 2 was patients who had primary debulking plus upfront chemotherapy afterwards. And Group 3 was patients who had debulking after previous treatments, but on progression. So, for example, chemotherapy, then there's tumor progression, so then we offered debulking surgery. Of these, most of our surgical approaches were a midline transcallosal approach in 60%. And we're able to achieve very satisfactory rates of tumor debulking. As you can see, most of our patients, 16 of our 21 patients, had a greater than 70% extent of resection. Sorry, that's 16 of the 22 operations. Complications were generally low. We did not have any patients having visual deterioration. We had 3 with an isolated diabetes insipidus, 1 with a transient hemiparesis, and 1 patient with infection. So by being careful about our patient selection, careful about our approach to surgery, what were our aims of surgery, and sticking to that carefully, we're able to keep the complication rate low. Radiotherapy was used for 5 patients in total, at a median age of 7 years, 7 months. So we're trying to leave that as late as possible. And you can see the algorithm below for those 5 patients. 2 patients had surgery followed by radiotherapy. As you can see, some had surgery followed by chemotherapy, followed by radiotherapy. But you can see also that surgery plays a repeated role for these patients. So you can have surgery at the front, but you can also have surgery required later on in their disease journey. So it's important to plan the treatments carefully and continue that liaison with the rest of the oncology team. So here's one case example of a young girl who presented in March 2001, aged 9 years old, with a gradual reduction in vision. So she was losing visual acuity, she was losing colour vision, and she had an increased blind spot. She also had precocious puberty. An MRI scan was performed showing a suprasellar, partly cystic tumour that was thought to be a probable glioma. Her scan actually showed, and you'll see that on the next slide, that she had a cystic component of tumour that was compressing the optic pathways. So her first operation was a right pterional craniotomy with biopsy of the tumour and aspiration of the cyst to decompress the optic nerves in chiasm and position. So you can see here, and on the sagittal scan on the right hand side, you can see that cyst that was compressing the optic pathways. So she had a measured, tailored, carefully planned surgical approach to preserve her vision by decompressing the optic pathways and take biopsies of the tumour to confirm that it was an optic pathway glioma, a pilocytic astrocytoma. She then went on and had chemotherapy. But about just short of 2 years later, there was evidence of further tumour progression. And you can see on these slides, you can see quite a lot of cystic formation within the exophytic component within the third ventricle. So following that, she then had a midline transcallosal interforniceal approach and tumour debulking. And you can see from that postoperative MRI scan that we have focused on the portion of tumour within the third ventricle, avoiding the tumour at the floor of the third ventricle, so preserving hypothalamic and optic pathway function, and also leaving a rind of tumour posteriorly as well to avoid injury to the brainstem and to the mammillary bodies so that we don't harm memory. So that's December 2002. She's had a limited debulk, an extensive debulk, but limited. We've left some tumour deliberately. And if we go forward 6 years, 5.5 years. The tumour remnant actually has involuted. We've got a stable scan and the tumour has involuted. So by leaving a tumour remnant to preserve function, we've managed to achieve long-term tumour control and preserved function. We've got that right balance between preserving function and achieving what we needed to do for oncological surgery. Here's another example. So this is a 1-year-old boy who presented with diencephalic syndrome, and like is fairly common, he had been investigated for some time for failure to thrive and for vomiting by general paediatricians. And you can see the large suprasellar third ventricular mass lesion with hydrocephalus. And you can see that clearly on this high resolution sagittal scan as well. So the treatment at presentation was to do an endoscopic biopsy of the tumour with a septum pellucidotomy and to insert a shunt to treat the hydrocephalus. And at this stage, he was unwell. He was malnourished and he was diencephalic. So I needed to relieve his raised intracranial pressure. I needed tumour tissue so that we could guide his chemotherapy decision making. So biopsy, treat the hydrocephalus. He then had chemotherapy, and you can see on these scans, labelled as number B, and these are in our book chapter, you can see this central necrosis within the tumour as a result of the chemotherapy that he was given. So that worked very well for his initial treatment, and it allowed him to gain weight, to get us over this vomiting, get over the diencephalic syndrome that he presented with. However, he did then gradually get some further tumour growth. And at that stage, when we had further tumour growth despite chemotherapy, we've got a point of treatment failure. So at that point, I then intervened and did a midline approach, transforaminal into the third ventricle, and debulked the tumour. And as you can see from the scans labelled as D, a deliberate remnant of tumour along the lateral margins and on the base, so that we could preserve his hypothalamic function and his visual function. This next example is of a 12-year-old girl who also presented with visual deterioration. Her treatment had started in another hospital. She'd had an open biopsy. She'd had via a terional route. But unfortunately, she'd had fairly short interval progression, leading to a second debulking operation, but again, only a small amount of tumour was able to be resected, only about 20%. So after this, she then had radiotherapy. As a result of the radiotherapy, she then developed Moyamoya disease, and she presented 9 months after the radiotherapy with TIAs and needed revascularization surgery. So she's had an open biopsy, a second debulking procedure, radiotherapy, and then needed revascularization. So this highlights the hazards and the challenges of treating these tumours in this group of patients. 1 year down the line from her revascularization, she then had further evidence of tumour progression and had brainstem compression signs as well. Chemotherapy was started but was abandoned because of it. And so you can see on these slides, she's got tumour that's actually, if you look at the top left slide, you can see that there's tumour that is compressing the left side of the brainstem, and you can see it distorting the basilar artery. So she had a retrosigmoid CP angle approach to debulk that portion of tumour, to decompress the brainstem. And this was facilitated by the use of intraoperative MRI to help us optimize the extent of resection whilst preserving function. So 3 different case examples giving you an outline, hopefully, of how we can do midline approaches or tailor a more unusual CP angle approach, but choosing our approach according to the tumour anatomy what is our goal of that surgery so that we optimize the extent of resection whilst preserving function, and that we have that tailored approach using our surgery as a tailored tool, tailoring it for that patient. And this gives you a flow diagram of our overall treatment pathway and algorithm for the patients that we've looked after and reported in our paper. So groups 1, 2, and 3, that stable disease was achievable with the primary treatment for a number of these patients, but that, for example, if we look at the initial surgery alone group, that we did still get tumour progression that did still need either repeat surgery or treatment with chemotherapy or radiotherapy down the line. So all of this comes through working very closely with a team of dedicated oncology and radiotherapy doctors. And these were our overall outcomes. So we had progression despite treatment intervention in 15 of the 42 patients during follow-up. So this is not just surgery, this is chemotherapy or radiotherapy as well, but we still saw that for 1/3 of our patients, we still saw some progression over time. Over the overall period of follow-up, we've got 93% survival. So 3 patients died, 1 from tumor progression, 1 died after biopsy due to a fulminant fungal infection. And then there was 1 patient who died 9 years after treatment from a posterior fossa hematoma that does seem to be unrelated to their primary disease and primary treatment. In terms of the function and functional status, we've managed to preserve vision in 70%. Despite intervention, we still get a progressive hypothalamic pituitary dysfunction. So some of this will be related to the tumour infiltrating these tissues. Some of this may also be the effects of the treatments that we're giving. So we started off with, for example, 9% of patients overweight at presentation, and this became 20% over follow-up. And so there can be a deterioration in this function anyway, even with our best attempts to preserve function. So this is where we've got to be careful and limit our surgery to make sure that we don't do harm, because the patients are going to be with us for a long time. If we look at the profile between those patients with neurofibromatosis type 1 and those without, we can see that those with NF1 generally have a more benign time course. You can see that progression only occurred in 11% of the NF1 patients, whereas it occurred in 50% of the non-NF1 patients. Similarly, chemotherapy requirement was much higher in the non-NF population. Similarly for surgery and radiotherapy. And as you'd also expect, therefore, those patients with neurofibromatosis have better rates of preservation of vision and a lower likelihood for disturbance of the hypothalamic pituitary axis. When we move into the follow-up and the monitoring, this also presents a further challenge. Typically, we do scans on a 3 to 6 monthly basis in the first year, and if things are stable, we can then carry on and progress to annual scans. But how do we assess the tumour? And this is difficult because linear measurements, as you will hopefully be aware, are error prone. Because if you're just doing a measurement in an axial slice or a coronal slice or a sagittal slice, depending on whether you're looking at a T1 post-SCAD or a FLAIR or a T2 scan, depending on the slice thickness, depends on the accuracy of those measurements. Volumetric measurements also are very time consuming, drawing around the tumour, what is tumour, what is swelling, what is gliosis, trying to work that out and delineate that for volumetric measurements is difficult and time consuming. We also know that there's no clear correlation between the imaging and the vision, and we need to improve on this. So we need better imaging to allow us to follow up and work out the natural history for surveillance of treatment, and to better understand the anatomy and relationship of the tumour and the surrounding anatomy, the anatomy-pathology relationship. Now, some of this is happening with radiomics, with this automatic segmentation, and there are various teams, and here's the work of the team in Tel Aviv, looking at some automatic segmentation to help us work out what bits of tumour are changing and what our treatment needs to be as a result. So you can have a baseline, start off with your baseline examination, and then you do a follow-up examination, taking your baseline demarcation and then adding on the corrected demarcation, covering the bit of extra tumour growth. So you can see at the back of the baseline demarcation on the left hand of the MRI scans, there's a little bit of white blush, which then gradually grows. And it clearly was tumour initially, but is more obviously tumour on the follow-up examination. And this allows us to look at that, compare across the two, and see this is our area of tumour growth, and what is it? But then we also can look at sub-segmentation of this. So we've got our area of demarcated tumour, and then we can do sub-segmentation into the cystic, into solid enhancing tumour, and solid non-enhancing tumour. And looking at this over time allows us to look at the profile of what is happening to that tumour over time. Now, this is not a straightforward thing, and this needs accurate computer modelling, but at the moment needs radiology and medical physics input to define this. But as you can see on these graphs, we've got the blue line in the middle of the graph showing us the solid non-enhancing tumour component. We've got the red line being the solid enhancing tumour, and then we've got green being cystic tumour. And the black line right at the top is our overall tumour volume. So you can see it as we move from left to right, we move to an area where the overall tumour volume is increasing. And actually, when you look at it, the greatest reason for that is that there is cyst formation within the tumour. So actually, what we may be needing to do is look at a treatment to actually treat that cystic progression. We've essentially gone through 3 phases of tumour change. We've got one, our baseline, then we've got a small amount of increase in all 3 components of the solid enhancing, the solid non-enhancing, and the cyst. And then we've gone into a 3rd phase where actually there's been a bit of further growth of the solid enhancing, non-enhancing tumour that's needed treatment, and then moving on right to the right where we've got the large cyst formation. So if we can take that model and apply that to our population of patients with these optic pathway tumours, this allows us to tailor our treatments and tailor our decision making. So have we seen, as we look at optic pathway tumour treatment, we need a careful team approach to treatment decisions. We need trust and collaboration between the neurosurgeon and the oncology team. And this is vital for us to get the best outcomes. This binocular approach between our oncologists and our surgeons working together, trusting each other to make the right decision at the right time. Careful goal setting, careful co-working. Survival is increasing. These patients are going to live with us for many, many years with the consequences of our actions. So we've got to be careful to make the right decision at the right time and not overstep that mark. Planned subtotal tumour resection is what we're aiming for when we're doing optic pathway tumour surgery. We're not trying to resect the whole of the tumour. We're tailoring the management plan to each individual patient. careful team approach, working together, careful goal setting. What am I trying to do? What am I trying to achieve? So the roles of surgery are a tailored approach. Surgery can be useful for biopsy, for tumor control, for relief of mass effect, and for controlling hydrocephalus. And we have a preference to try to debulk tumor further, to try and postpone or even obviate the need for radiotherapy. If there's a chance to do further surgery to try and debulk tumor, and that can put off radiotherapy to being needed later on in life, then that is preferable. And that's our local preference anyway. But it's all about working carefully with your oncologist to make sure the right treatment decision is made at the right time. We've found intraoperative MRI has been a useful surgical adjunct, helping us further define the extent of our resection, helping us to further achieve that maximal safe resection whilst preserving function. So, as we consider the overall role of surgery, we need to take that with the non-surgical treatments. And I'll leave you with this quote. So the selection and testing of surgical and non-surgical treatments requires an active international trials program. So we've got to treat these patients on a trial program. And we've got to include patients with newly diagnosed cases and patients requiring second line and third line or subsequent therapies as well. So we want to take all the data from our treatment with surgery and non-surgical treatments, incorporate in clinical trial settings, and use that to learn and develop our treatment strategies. So hopefully that gives you a good overview of optic pathway tumor treatment in general, as well as specifically the surgery and some of the surgical anatomy of this treatment. Thank you very much.